Using a monoclonal antibodies and using a tyrosine kinase inhibitors has several differences. In one case, you clearly target one point, so you are targeting one receptor. In the other case, you are targeting multiple points. And this is the reason why the tyrosine kinase inhibitors have a broad spectrum of action, and they target multiple kinases, not only VEGF. And this is the reason also why they have a different toxicity profile from targeting only VEGFR2. So in one case, we have oral drugs with a different toxicity profile. Diarrhea can be something which is different between the two drugs, but they are oral, but they also pay to be oral because they have a variable pharmacokinetics from the monoclonal antibodies. So targeting in all the cases angiogenesis, we have a different type of targeting of angiogenesis. If we look to the results of the REVEL study and all the results of the LUM-LUNG study, we can see that more or less the hazard ratio is similar at the end, at least for adenocarcinoma. But in the case of the REVEL, we can target all the histologies. In the case of the LUM-LUNG, we can use the drug only in adenocarcinoma. Then there are some other differences in the study. The main difference is that the LUM-LUNG study has the primary objective, the progression-free survival, and the REVEL study has the overall survival. But at the end, they gave similar results. So I think that we have to discuss with the patient that we have different toxicity profile. In one case, we can have the possibility to give an oral drug, and the other possibilities we can give an intravenous drug. I think that, for example, again, if the patient is taking several pills for the disease, it's quite difficult to give another oral drug, both for the compliance but also for the pharmacokinetics of the drug. So in my opinion, we will decide case by case with the patient and what is the best for each patient.
In this case, there really are no TKIs that we would use against VEGF in lung cancer. But in general, when I'm thinking between a monoclonal antibody and a TKI, a monoclonal antibody is IV and a TKI is normally oral. So of course, it's a little easier to give a TKI, all else being equal. However, a monoclonal antibody is much more specific. It's monoclonal, it's against one target, whereas a TKI, a tyrosine kinase inhibitor, can have many effects on many different kinases. And depending on the dose that you use, that's why you're getting the toxicities, the skin and the GI and other side effects, general fatigue. So, if you have a monoclonal antibody and it's specific and it works, of course you'd want to use that. Fewer pharmacokinetic interactions too, by the way.